Hi, everyone. This is Mitul Patel from UC San Diego, here to provide some commentary regarding the case that Doctors Abdullah and Shishapur just shared with you of a patient with critical limb ischemia. I want to thank SCAI and specifically the Vascular Disease Council for inviting me to provide this commentary, as well as to thank Doctors Abdullah and Shishapur for sharing a very complex case that required really masterful endovascular work. So those on this call are probably aware that critical limb ischemia is the end stage equivalent of peripheral arterial disease. However, as opposed to many other end stage diseases where organ transplantation may be the treatment option, ultimately for end stage critical limb ischemia patients, the only treatment option remains amputation and possibly a prosthetic limb, which, as many of you know, does not provide the functionality that a native limb would provide. Many of you may also know that about 20% of patients that undergo invasive angiography for critical limb ischemia do not have endovascular, or for that matter, surgical options due to lack of distal targets, as was nicely demonstrated in the case just shown. In these circumstances, amputation remains the only option, and due to lack of functionality as well as the comorbid factors that lead to critical limb ischemia, namely diabetes, end-stage renal disease or chronic kidney disease, advanced age, and really calcified peripheral arterial disease, the combination of those diseases really portends a very poor prognosis. In fact, in many series, at 6 months, those that undergo even limited amputations, about 1 in 5 patients ultimately die within that 6-month follow-up period. So hopefully I don't have to convince anybody listening to this webinar that this is obviously a very morbid disease with very limited options in at least 20% of patients, namely those without distal targets. However, as Drs. Shishapur and Abdullah nicely demonstrated here, a case of deep venous arterialization for the treatment of patients with critical limb ischemia without any form of distal endovascular or surgical targets. You can see that in order to undertake this type of procedure, you have to have a dedicated skill set of endovascular, complex endovascular revascularization methods. You saw that in this particular case, Drs. Abdullah and Shishapur used an outback catheter. Hopefully, those that are performing complex peripheral cases have plenty of experience with how to use reentry or dedicated reentry devices such as the Outback or Pioneer Plus catheters. In addition, you have to be very comfortable with managing CTO wires. Obviously, the deployment of stents is pretty basic, but knowing how to get endovascular access in the distal, both venous and arterial vascular beds, is also another skill set that is necessary to complete these procedures. In addition to your skill set as an endovascular operator, you should really surround yourself with the best multidisciplinary team to help support your patient and help improve your outcomes. You can see that this patient that was shared in the case just presented obviously was evaluated by a multidisciplinary team, including surgeons capable of distal revascularization procedures, as well as wound care specialists, possibly endocrinologists, nephrologists, all the necessary personnel that help with optimal outcomes. And multiple data sets have shown improved outcomes for patients with critical limb ischemia when treated in a multidisciplinary format. So the procedure that Drs. Abdullah and Shishapur just showed you with deep venous arterialization has also been evaluated by a study called the PROMISE-1 trial, which uses a technology called limb flow technology that is specifically dedicated to the process of deep venous arterialization. Within that toolbox, There are ultrasound catheters for both the venous and arterial delivery that help you center your puncture across the artery into the vein, thus minimizing potential trauma and improving the crossing from artery to vein, and then help you externalize the wire and subsequently help deliver not just a nitinol cage that helps create valvotomies. You can see that in the case just presented, they used non-compliant balloons to essentially create balloon expansion or stent expandability at the site of the venous valves. There's a dedicated system with the lymph flow system that helps accommodate this with blades and a nitinol cage. And finally, covered stents that lead to the ultimate arterialization of the venous system. These patients are, as I mentioned, not infrequent, and thus techniques such as just demonstrated in this case are really paramount to help us get to those 1 in 5 patients that have no distal targets. Many are familiar with stem cell trials and trials with prostanoids that have not really panned out for these patients that have essentially the desert foot or no surgical or endovascular options. And thus, again, I really want to congratulate Drs. Abdullah and Shishapur on a masterful case and for sharing this knowledge for the benefit of the vascular disease specialists, especially the endovascular specialists that are out there. Thank you for your time.